come back to you, Rami, and we're going to get back on track for those patients where we remember that we do cure people with intensive chemotherapy, right? Okay, and there's been a lot of talk about using measurable residual disease assays, MRD assays, for guiding therapy. Walk us through how you think about consolidation, how many cycles of consolidation, transplant, and where MRD comes into decision-making about those choices.
Right, so obviously, I think we can start with the group that we know most about, the patients that have core binding abnormalities, that those patients benefit from intensive chemotherapy, as you alluded. Nowadays, probably adding gemtuzumab as well for those patients. And in those patients, the role of consolidation is very well established. Typically, they should get 3 to 4 rounds of consolidation with a curative intent. The other groups, I think, obviously, again, once we get into a remission, that the role of consolidation can be sometimes controversial a little bit. How many cycles are ideal? I think we've kind of shied away from doing the high dose cytarabine in the non-core binding, so we do lower dose cytarabine. And the exact number of rounds is not known, somewhere between 2 to 4 rounds of treatment. And it gets a little bit even more controversial in older patients, like what's the benefit of consolidation in general in older patients, how many cycles? I think most people agree that maybe some consolidation is better than none, 1 to 2 cycles. So that's where also comes the role of assessing the disease, looking at the MRD status for the disease. And I think when we refer to MRD status, it's like a very generic description we are talking about. So first, to make a point that when we are talking about the NGS panels that we are using, those are not MRD measurement, because they have a certain threshold of 5 to 10%. When you are saying the next generation sequencing test is back negative, that means we are below the level of detection. We are not a true MRD status. The MRD status can be checked by molecular mutations, but it can also be checked by flow cytometry as well. And I think that's an evolving field. Sometimes even myself, I'm confused about what to do with that data. If you are MRD negative, you are going to do better. But do you want to go to transplant if you are MRD negative or you are MRD positive? Technically or theoretically, if you are MRD negative, you're going to do better with the transplant. But can you avoid it? And MRD positive are going to do worse with the transplant, but they are probably going to have worse outcome without going to the transplant. So it really gets so confusing. And you think about this all the time for patients, what to do. There is no doubt that transplant remains still a curative strategy for a lot of the patients. And there is no doubt that the MRD role is evolving. I think in the ALL, the field is ahead of us than AML. But what I can say is MRD negativity is a good thing to achieve. So.
Well, but in ALL, they have a reliable ALL,
right.
a reliable MRD assay. In AML, I'm like...
And a drug.
Right. And drug.
Both erase it, yes.
So Naval, you get back your NGS panel. Does it matter what is still positive while you're in remission? Does that make a difference?
I would say in a general, in a sweeping statement situation, not much. It doesn't change my approach. I think a couple of things what Rami said are very, very important. For practical decision making, if I decided at baseline that this patient is intermediate or high risk and transplant was my goal, and I get the patient in morphological remission in AML, again, very different from ALL, and transplant is lined up, I would proceed to transplant, whether he's MRD positive or negative. Now, my transplant colleagues may push back, and sometimes they do and sometimes they don't. We all agree that MRD positive transplant doesn't do as good as MRD negative, but it seems like it does better than no transplant. And I think that's just kind of the, what's the saying, don't let perfect be the enemy of good situation. So I think that's kind of how we're using MRD for transplant-related decisions.
But we learned from the HOVON analysis that certain mutations present at the time of remission, ASXL1, TET2, DNA methyltransferase 3A, don't seem to impact on long-term prognosis. Does that mean that patient doesn't need a transplant? Dan?
Wow, this is we struggle with this all the time because those DTA mutations that persist and don't, according to the New England Journal of Medicine paper, don't impact long-term outcomes like survival, appear to be associated with a chip-like status or a reset to a chip-like status. And so, I think that based on the data from that group in that paper, it's not unreasonable to not consider those mutations as MRD markers. But the question we struggle with is in an individualized basis, well, what else could be CHIP that's not a DTA mutation? DTA fell out of that analysis because they're so common. But I think that in an individual patient, IDH can be a CHIP mutation and multiple others. So how do we know what's important and what to ignore? At the moment, we don't.
Right. The other area that the MRD status come actually is a good risk group. Like if you did treatment for those patients and they have persistent disease, are you going to take them to transplant? No or not. I think there's probably more role there. Like if somebody is like NPM1 still positive status, core binding like those patients may benefit actually in that way.
And to your point that, well, what do we do? The transplanters don't want to take the patient who's MRD positive, but in fact, their own data is showing clearly that trying to make that MRD go away by hammering the patient doesn't really help.
That's a really important point. I was actually at one of the oral sessions for allo transplant. Some of my colleagues wonder what I was doing
at
there.
the same session.
Very important information for us because the data from Fred Hutch that was presented by Jason Applebaum actually addressed that. They didn't actually specify to a physician whether the patient needed to be MRD positive or MRD negative prior to a transplant. They left it to the doctors and the patients and the transplanters to decide. But what they showed was patients who were MRD positive who received intensive chemotherapy or any chemotherapy prior to going to transplant actually had a worse outcome. Many of them didn't become MRD negative because they were already defined to be chemotherapy resistant. And so not obviously a randomized trial, and they're thinking about doing that, but it does suggest that maybe beating on these patients with more chemotherapy isn't the way to go. What we need to find out is maybe immunotherapies or different approaches might improve their outcomes.
Right.
Yeah.
We presented the similar data at this meeting, albeit in the poster session. No one named Applebaum was on our paper. But very interesting that if you're MRD negative, you do better. If you're MRD positive, you do worse. And it doesn't matter if you're MRD positive going into a transplant if we tried to consolidate that MRD away. You still do as poorly as an MRD positive patient. So, this is not an ALL situation. We would love to be able to mop up MRD, but can we, and will it matter, and how will it matter?
So as moderator, I'm going to say something to pull this together and then go on quickly so no one could disagree. But it's really important for the people listening to this because there's a lot of hype about MRD. And I would say, why are we spending a lot of money on the individual patient outside of clinical trials, not in clinical trials, but outside of clinical trials, getting this information? It may actually subvert the best option for therapy for those patients, and you're spending money. This is different than a guided PCR analysis for FLT3 or IDH where we have therapeutic targets. But this NGS panel or flow cytometry, I see as just adding expense to the care of patients with AML without a proven benefit yet. And I would not recommend doing that outside the context of a clinical trial where the assay is being developed appropriately.